Hello, let's get back in it and talk about tumors of the epidermis. I know I'm a bit behind on these dermatology videos. To tell you the truth, derm is kind of souring on me ever since I went to a melanoma lecture and they start rattling off the risk factors, right? And I kind of slowly realize I'm gripped by the horror, I'm like, oh my word, I check every single one of these boxes. And it's like, uh, pale skin, check. Blonde hair, risk factor, check. You got like a 3 times chance if you have blonde hair. Blue eyes, it's like check. And then they're like number of freckles. And I know I told you in that melanoma video, don't take your time to count the patient's freckles. But I was sitting in this lecture and I start just looking at my arms and I'm counting the little dots on my arms and I'm like, whoa, hold up. I've got 100 freckles on my arms alone. So ever since that, it's like, yeah, I'm going to get a melanoma at some point. So derm has been one of my least favorite subjects ever since then. Let's talk about epidermal tumors now. I've pointed out here with the letter Q, 5 different things I think you're going to get tested on. If we're to assume, no overlap between questions and 5 from this STL, I think that you are going to get asked about both Seborrheic Keratosis and Acanthosis Nigricans, which are benign tumors of the epithelium. I believe you'll get asked about Actinic Keratosis, which is the pre-malignant lesion for squamous cell carcinoma. And then, of course, I think you will see one question on both basal and squamous cell carcinomas. So getting into Seborrheic Keratosis, what you really want to know is that if you see a patient and they have these Seborrheic Keratoses all over their back, that's called the Letzler-Trelat sign. And what that means is that the patient's got an adenocarcinoma. And so they'll show you one of these photos, literally probably one of these exact photos, and they'll say, what's the patient got? And the answer is going to be an adenocarcinoma of the stomach or the duodenum or the breast or the ovaries, any organ, the lungs, any organ that's got glands can develop an adenocarcinoma. So this is technically a paraneoplastic syndrome representative of that underlying cancer. Whenever you don't see the systemic seborrheic keratosis, here's what a single or a couple of them would look like. Notice they're palpable and they kind of have some fissures in them and they stick up. They're very dark, very pigmented, and even a little bit oily. I've seen them described in question stems. And you always see these things called horn cysts, and these are cystic. They're not technically cysts because they're not fluid filled, but they're cystic pouches within the epidermis. And you can tell that there are flattened keratinocytes occupying these cysts and that they're all kind of squished together. Like if you took a piece of paper and balled it up, that's what these horn cysts look like. They can be palpable again, and they can go very deep into the epidermis, even sometimes intruding into the dermis. So here's a close-up again of these horn cysts consisting of flattened epithelial cells. If they ask you, what do you see on histopathology? And the diagnosis is seborrheic keratosis. This is what you see. You see cystic caves or cavernous spaces occupied by these wads of flattened keratinocytes. So what does the STL say about seborrheic keratosis? The lesions are raised above the skin surface. Again, they're palpable, they're exophytic. And you see hyperproduction, overproduction of keratin with keratin-filled cysts. Again, they're dark lesions. They're due to activating mutations in FGFR3, that's the fibroblast growth factor receptor. And remember, we have one other disease that we associate with the fibroblast growth factor, and that's going to be achondroplasia, recall. And here's the money shot, what you want to know, the top of page 4. Seborrheic keratosis may occur explosively in large numbers in patients with GI, breast, and lung carcinomas. So again, those are adenocarcinomas, glandular cancers, as part of a paraneoplastic syndrome called Letzler-Trelat sign. And again, when we say explosive eruption of these seborrheic keratoses, they are all over the patient's body, typically truncally located. Now let's talk about Acanthosis Nigricans. Acanthosis is a proliferation of the epidermal keratinocyte layer. So there's just too many keratinocytes in the epidermis. It's a hyperplasia, not a hypertrophy. And because keratinocytes contain a lot of pigment, remember melanocytes make pigment, pass it off to the keratinocytes, like when you're running the option in NCAA football. And so because there's more keratinocytes, there's more melanin in these keratinocytes as well. Each keratinocyte contains melanin. And so the area affected by Acanthosis nigricans shows up as a little bit darker, deeper pigmented than the surrounding skin. Typically, it's on the neck, and the axilla is another common place. And when you see this finding on physical exam, it's one of two things. The patient either has diabetes or they have an underlying cancer, and that's usually what they like to ask you about rather than what does it look like on histology. If they do ask you, what does it look like on histology, you're in luck because the answer is in the name of the diagnosis. You see acanthosis, which is, one more time, just a simple hyperplasia of the epidermis. Again, there's too many cells there. And you might even see these things called prominent papillomatoses. And papilloma, when we think of a papillary structure, that means it's like a sea anemone. That's the image I evoke in my mind. When I see papilloma, I'm thinking it's got fronds and fingers like a sea anemone. And you can look at this epidermis and you can tell it's wavy. It's got these finger-like, frond-like projections, both going outward and growing down inwards into the dermis. And so that's what we refer to when we say papillomatosis. Let's check out the SDL on Acanthosis nigricans. It's associated with obesity, okay, and endocrinopathies such as pituitary disease and diabetes, right? Diabetes and obesity go hand in hand. And when seen in individuals older than age 40, Acanthosis nigricans is commonly associated with an internal malignancy, usually an adenocarcinoma. And so this is really good news because that means that both Seborrheic Keratosis and Acanthosis nigricans are associated with the exact same type of cancer, the adenocarcinoma. You will have no problem remembering this. Pathology, what do we have? Lesions show papillomatosis with enlarged dermal papillae, undulating sharply to form numerous repeating peaks and valleys. So again, undulating, finger-like, frond-like. It's a papillomatosis, meaning it's kind of like a papilloma, but it's not a papilloma. In the benign form of Acanthosis nigricans associated with obesity and diabetes, it is probably insulin or insulin-like growth factor 1 that induces the epidermal proliferation. This should make a lot of sense. Insulin is an anabolic hormone. It's going to make your cells build proteins rather than break them down. And in the malignant forms of Acanthosis nigricans, we believe that it's linked to TGF alpha, transforming growth factor alpha. I don't think that's the highest yield point. They really just want you to understand this is associated with diabetes and adenocarcinomas. Now let's talk about the cylindroma. It's a benign tumor arising from the eccrine sweat glands. So I don't think you'll get asked about this, but if you do, here's what you'll get asked. Where did this tumor come from? And the answer is going to be sweat gland. The other options could be like epidermis, melanocytes, dermis, like lipoma, fat. So that's your answer. It's a sweat gland tumor. The tumor shows nests of cells, that's a key word, with a characteristic jigsaw or mosaic appearance at low power. And this is what we're talking about. You see how all of these, the tumors got kind of septae in between individual parts or pieces of the tumors that are fitting together, kind of like puzzle pieces. I haven't done a puzzle in a long time, but had some really good ones in my life. You know, those like once you start getting up to the 4 digits, 1,000 pieces, you know, it's like I'm not that much of a puzzle buff, but I do like a good puzzle. It's a good way to just go brainless for a bit. Cylindromas can be associated with this autosomal dominant Brooks-Spiegler syndrome, in which there's inactivation of the CYLD tumor suppressor gene. So no problems there. CYLD cylindroma gene. All right. That's nice and easy. There's not much else to know besides that about this tumor. Here's a syringoma, which characteristically likes to present right under the eyes or on the eyelids. And they are also tumors of the eccrine sweat ducts. So first we had 2 tumors, both associated with adenocarcinomas. Now in this SDL, we've got 2 tumors in a row that are both associated with eccrine sweat ducts. And if you remember, the syringoma is around the eyelids. You're going to have an easy time differentiating this from a cylindroma. They're pretty common lesions. They can get confused with a sty or a carbuncle, which I guess would just be a little blockage of one of those glands around the eyelid. And what you want to know is that the syringoma is technically an adenoma, or a benign tumor of fatty origin, and it's an adenoma arising from, one more time, that eccrine sweat duct. That's really all you want to know about this. Now let's talk about actinic keratosis. You are going to see a question about actinic keratosis. What you want to know, number one, it's going to transition into a squamous cell carcinoma more often than not. It does say, yeah, it can be a basal cell carcinoma, but that is a minority of the time. The majority, 2/3 of the time, it's going to be a squamous cell carcinoma. So even though it can be a basal cell carcinoma, push that out of your head when it comes to boards. Get that idea, crumple it up, throw it in the trash can. You want to associate AK with the squamous cell carcinoma. So people who get actinic keratosis are people who stay out in the sun a lot. UVB light is the predisposing factor to getting actinic keratosis. So this will be a farmer or a gardener or a construction worker, somebody who is out in the sun for the majority of the day. They work outdoors, and sun exposure, again, is the risk factor for this premalignant lesion, which is the precursor for squamous cell carcinoma. These lesions are rough and have been compared to rubbing sandpaper, so don't get it confused with your, seborrheic keratosis, which is also palpable. These actinic keratosis tend to be a little bit more erythematous, and they're really not pigmented at all compared to the seborrheic keratosis, which also has keratosis in the name. So actinic keratosis, you hear that, you think actin, and actin, you know, is an intermediate filament that kind of holds cells together. It's like the framework of your house, correct? And so actinic keratosis means that there's going to be a problem with actin somehow. And if we look at it under a microscope, we see that there are atypical keratinocytes kind of nested in those deeper layers of the epidermis, and they're going to be much, much larger than they should be. Actinic keratosis does like to scale over or crust over a little bit. We can zoom in on this patient's hand on the right, and we can see again, that is a dry lesion. That's how I would describe it. That is a flaking lesion. You might even call it a little bit crusted, and it is certainly kind of pale yellow or white or tan. So that's what actinic keratosis looks like grossly. Back to the SDL. Actinic keratosis is characterized by the presence of atypical keratinocytes at the lower half of the dermis. So AK, actinic keratosis, atypical keratinocytes, both of them AK right there. All right. And the superficial dermis contains thickened blue-gray elastic fibers, and this is called elastosis, and solar elastosis is the name that we give to benign sun damage. But we're going to observe elastosis in this lesion, but we're going to call it something different because it's not benign. So to recapitulate that, you got a sun lesion leading to elastosis. If it's benign, we call that solar elastosis. If it's pre-malignant, we're calling it actinic keratosis. How do you tell them apart? Well, solar elastosis just has this dermal finding with increased elastic fibers, and then actinic keratosis is going to have that plus atypical keratinocytes. And then there's Bowen disease, which is always erythematous. Every single time it's erythematous, it can scale much like the actinic keratosis that we just looked at. And you typically, we've seen Bowen disease before. Where have we seen it? It's a pre-malignant, it's pre-squamous cell carcinoma of the penile shaft. And then if it were on the head, it would be called the erythroplasia of Carrot, right? So we've seen Bowen disease before. I don't think we need to go over that. You know what that is. Histologically, in Bowen disease, you do see acanthosis, hyperkeratosis. So not too much special. You're just diagnosing that for its location on the body. Now let's talk about malignant epithelial tumors. First, there's the Keratoacanthoma, which looks like a volcano. It's kind of a punctate lesion. It's like a zit, you know, that's right about to pop. It is very palpable. And what gets mentioned a couple times in the SDL is that it will spontaneously resolve. So this looks kind of like one tumor that's in the dermal tumors SDL, the next SDL. So that's your differential. Don't get it confused. I don't think you would get this confused with a squamous cell carcinoma, because this always is kind of circular. It's like perfectly circular, kind of like a wart, or again, a zit. And for the third time, this SDL mentions 50% of them undergo spontaneous resolution. So I believe that would be in any question stem about this Keratoacanthoma. And they want you to know that the middle of the tumor is technically keratin. It's a keratin plug. And when this tumor resolves, self-resolves, it's because that keratin plug gets squeezed out somehow or just kind of falls out on its own, and then the cells inside can heal. So again, it's cup-shaped. It's like a volcano with a keratin eruption. And there is also an inflammatory infiltrate consisting of immune cells at the base of the lesion. Here's a couple photos I have of a keratoacanthoma. Again, it's just like a volcano. It will erupt, and when it pushes that plug out, it will spontaneously resolve. Let's walk back a little bit. I did have a practice question for actinic keratosis. Here's how they ask about AK. Here's a 57-year-old man showing up with lesions on his ear. The lesions are excised and sent to pathology. Results indicate they are not cancerous. Within 6 months of removal, one of the lesions reappears and is shown below. The physician explains to the patient that he may be at risk for developing a type of skin cancer that carries a risk of metastasis. What is a feature of the malignancy this patient is at risk for developing? So let's check out the options. Keratin formation. Well, you know that that is absolutely referring to a squamous cell carcinoma. So that's in play when we're talking about AK. And then there's something metastasis based on Breslau depth. Now that's talking about a melanoma. Actinic keratosis is not a precursor lesion for a melanoma, so you would strike that one off your list. And then there's palisading cells at the periphery of the tumor. That would be a basal cell carcinoma. And then there's pearly papules with telangiectasias. That would also be a basal cell carcinoma. And then finally, there's pinpoint areas of bleeding from exposure of dermal papillae. That right there, I believe, is psoriasis. So that's not even a cancer. So you can get that one out of there. And so two of these answers are basal cell. And so you got to cross them both out. And then you're left with squamous cell carcinoma. That's the correct answer. So this is what I was referring to. Get that out of your mind. Actinic keratosis is associated with basal cell carcinoma. I don't care that the SDL says it. For your purposes in mind, this thing leads to squamous cell carcinoma. Don't get it confused. Here's Bowen disease. Again, it's always, every time this is erythematous, it's been described in SDLs as having circumscribed borders. This doesn't look very circumscribed to me. I don't know. I mean, it's like, you can kind of call it whatever you want if you're a dermatologist, but me, a lowly medical student, my opinion doesn't matter. And then here's what you see if you look at Bowen disease histologically. Acanthosis, which is, one more time, a simple hyperplasia or proliferation in quantity of keratinocytes in the epidermis. So getting back on track, let's talk about basal cell carcinomas. This is the most common malignancy in humans, and average lifetime risk for white people is 30%. The risk factor is UV light, sunlight. That's what they're going to ask you if they ask you about risk factors. And it's almost the same thing for squamous cell carcinoma. There are a couple extra ones for squamous cell carcinoma. Genes involved with basal cell carcinoma, we got two of them. First, there's P53. Second, there's patch PTCH. And both of these are tumor suppressor genes, so keep those in your pocket. There is this phenomenon called Gorlin syndrome, in which patients have tens, many basal cell carcinomas. It's an autosomal dominant disorder, and it's associated with that patch PTCH gene. And Gorlin syndrome is also referred to as nevoid basal cell carcinoma syndrome. So these patients, again, have basal cell carcinomas all over the face, neck, and trunk usually. And this is autosomal dominant. That's really what they want to test you on, is the inheritance pattern of it. About 85% of all basal cell carcinomas are in the head and neck region. Now let's look at some photos of basal cell carcinoma. They like to grow on the upper lip, whereas squamous carcinomas of the skin like to grow on the lower lip. The way that you're going to remember this is that the upper lip is the part of the lip that's got the little dip in it, right? That's right next to the philtrum connecting the nose to the mouth. And so because the upper lip is shaped like that, it almost looks like the upper lip is shaped like a B lying flat on its side. And so the lower lip isn't shaped like that. The lower lip is shaped like a D or a straight line if you're this leading. And so again, the upper lip, it's got that little dip in it in the middle of the lip. And so it's kind of B-shaped. And so you're going to remember the basal cell carcinoma tends to present on the upper lip. These basal cell carcinomas can get kind of large and red and erythematous and pearly papules, again, on an erythematous base with telangiectasias. That's an important way to describe this gross presentation. But what you rarely see in the basal carcinoma is ulceration. If it starts to scab and peel and bleed, then you're thinking squamous carcinoma of the skin. Here's a basal cell carcinoma. Notice it is a pretty purple on histology. You don't see pink, and so this could not be easier to tell apart from a squamous cell carcinoma to me. Something that you see characteristic of basal cell carcinomas in the skin is palisading nuclei. We've seen palisading before with glioblastoma multiforme in the brain. Here is a little bit better example of it. Notice how the nuclei of this tumor are all lined up at the periphery of this little nest, and that there's a little bit less nuclear density in the middle. So again, it's kind of like crust on a pizza. All the nuclei are on the crust, and then there's cheese in the middle of the pizza. So just like a normal pizza, that's what we think of when we think palisading nuclei. We can zoom in on some of these other lesions, and you can tell here are all the nuclei around the crust of the pizza. And again, there's cheese in the middle of the pizza. If you look at it again without the highlights, you can see exactly what I'm saying. Here's one more example. Here's a nest of tumor cells, and so there's the edge of our pizza. Can you see that the nuclei of this nest are around the crust of the pizza and they're not in the middle where the cheese is? That's what we mean when we say palisading or pseudopalisading. We mean that the nuclei of a nest of tumor cells are arranged on the crust of the pizza. So that's a basal cell carcinoma classically. Here's a question, and let it ease your mind. They do like to ask easy questions about these skin cancers because there are a few options in the differential. Here they just show you the histology. They tell you it's a flesh-colored shiny lesion, 1.5 centimeters in diameter, and dude is a landscaper, and so he's got a long history of UVB light exposure. And even if they didn't show you this histology, you could probably take a great guess at this question. You could rule out melanoma and seborrheic keratosis on the principle that this is not a pigmented, dark-colored lesion, right? And then you could rule out actinic keratosis, I guess based on the fact that it's not crusted over or ulcerated or anything. Remember, those actinic keratoses tend to scab up, and so then dermatitis herpetiformis, that's like associated with celiac disease and CD only, and that's a vesicular erythematous rash. So you're left with basal and squamous cell, and remember what I said, squamous cell likes to ulcerate and bleed and look all ugly. Basal cell carcinomas tend to have pearly papules. That's your buzzword there. They look like pearly papules. And so when they say it's a shiny lesion, you're like, all right, basal cell carcinoma. And the histology is just icing on the cake there. So a couple more examples of basal cell carcinomas. Again, notice that they are purple and not pink. They could not look any more different than squamous cell carcinomas. Here's another basal cell carcinoma. Again, it is purple, not pink. So now let's discuss squamous cell carcinomas, which do like to metastasize. They can get pretty malignant, go elsewhere in the body. Actinic keratosis is the precursor lesion for squamous cell carcinoma. They are common on the scalp, on the backs of the hands, and on the superior surface of the pinna. That's basically the ear, the cartilage of the ear. And basal cell carcinoma is very rarely found on these sites. So one more time, the scalp, the backs of the hands, the cartilage of the ear. You see a skin cancer there, it is most likely squamous cell. Cells are polygonal with abundant eosinophilic cytoplasm and large nuclei, which are hyperchromatic and polymorphic. You see keratin pearls, you see pink nests. These Gross tumors do like to get all red. They like to ulcerate. They might even bleed. Again, you see intercellular bridges and keratin pearls, characteristic of almost any squamous cell cancer. What are your risk factors? Sun exposure, just like basal cell carcinoma. UVB light makes thymidine dimers, right? Thymidine is a pyrimidine. And then immunosuppression as well. That's pretty unique to squamous cell carcinoma. We're not too sure why that happens, but we do know that it happens. Other factors include tars and oils, draining osteomyelitis, scars from burns, ionizing radiation, and tobacco, oral tobacco consumption, and smoking tobacco as well, because squamous cell carcinomas can pop up in the oral cavity. The gene involved in a lot of squamous cell carcinomas is going to be that P53 gene. So that's the same one you see mutated in basal cell carcinomas. Let's look at some squamous cell carcinomas. Here it is on the lower lip. Notice it's, oh man, that's ugly. It looks like lasagna. It's crusted. It's yellow and red. You know, that is not clean, whereas the basal cell carcinoma was a lot more presentable. You know, you could at least show a basal cell carcinoma to your mom. But this squamous cell one, oh man. Then you look at it under the microscope. It's so pink. It's Barbie pink, hot pink, highlighter pink. Pick your favorite pink, you know, bubblegum pink, hubba bubba pink. There we go. So you look at it again and you see these nests of keratin pearls. This is so easy, yo. Here's a 56-year-old man who is a farmer and he's got an ulcerated nodule just below his lower lip. Biopsy is obtained. You see keratin pearls. That is an easy squamous cell carcinoma. Then the SDL talks about Xeroderma Pigmentosum. What you want to remember is that this thing is autosomal recessive. It does single nucleotide excision repair. That's going to be the test question if they ask about this. It's the XP genes, XPA, B, C, D, XP, Xeroderma Pigmentosum. Again, what do they want to ask you? Oh, what's the mechanism of the gene that's out? And they'll give you, I don't know, homologous end joining, you know, or like repair of double-stranded DNA breaks. Well, it ain't those two. You know, it's nucleotide excision repair. You have a problem with one nucleotide. You take it out. You put the appropriate nucleotide back in its place. That's nucleotide excision repair. And this normally functions to repair thymine dimers. And remember, UVB light creates thymine dimers, which is why patients with Xeroderma pigmentosum step outside and they start getting skin cancers and freckles almost immediately because they cannot repair the thymidine dimers induced by exposure to UVB light, and so they end up getting multiple skin cancers. Then there's the Merkel cell carcinoma. I don't think we'll get asked about this one either. It's a neuroendocrine tumor of the skin, and so it's really not a, I mean, how are they going to tell you this patient has a neuroendocrine skin tumor and you not know what it is? Well, melanomas are also neuroendocrine, you know, they're neural crest cells. So I suppose melanomas are in the differential, but you know, I mean, this thing grossly, that don't look like any melanoma I ever seen, you know, even in black and white. And so you'll look at it and you'll see nests of these neuroendocrine cells in the dermis. And what you would probably get asked is, what does the Merkel cell do? Because that's the cancerous cell. Understand the Merkel cell does deep touch, not light touch, not fine touch. Those are Meissner's corpuscles. And the way I remember that, by the way, is that Meissner's has that I vowel sound in the middle, and so it does fine touch. That's how my brain works. So Merkel cells, just remember it's the M1 that does the opposite of Meissner's. If you remember Meissner's, you remember Merkel cells doesn't do fine touch. And so what's left? Deep touch. It helps you make out edges. So like if you've got a box, like a present, you can feel the edges of the cube. Those are your Merkel cells firing when you do that. So that's probably the question there. These Merkel cell carcinomas stain with cytokeratin 20, as well as chromogranin A, NSE, synaptophysin, all of our friendly neighborhood neuroectodermal markers. It's a small round blue cell tumor. That's also not a surprise. One more time, it stains with cytokeratin 20. And the big treatment or risk factor is going to be UVA light treatment for psoriasis. Because remember, if a patient's got psoriasis on a surface area that's less than 1/5 of their total body area, we're going to treat it with topical steroids. But as soon as you cross that threshold, and let's say half of their body surface area is involved, you can't just expect someone to lather themselves, in cortisone like twice a day, every day. It's like it's kind of a laborious task. And so then that's when you consider putting these patients with expansive psoriasis inside the tanning bed, kind of under that UVA light. And that does really help the symptoms of psoriasis. However, a bad part about that is that it does increase your risk of Merkel cell carcinoma by 100-fold. So that's what you could get asked about the Merkel cell carcinoma. What was the risk factor that disposed this patient to this cancer? And that's going to be UVA light and psoriasis. And then they could also ask you, what's the function of the Merkel cells? Understand that does deep touch. So that's it for this epidermal tumors SDL. Thank you very much.